Hello, my name is Ki-Jinn. I'm an associate professor at the Department of Anesthesia at the Toronto Western Hospital, part of the University of Toronto. And it's my pleasure today to talk to you about the Erector Spinae plane block, or what we like to call the ESP block, which I truly believe represents a new paradigm in regional analgesia. Before I begin, I'd like to acknowledge that the ESP block is the product of a tremendous collaboration internationally between many people to whom I owe a debt of gratitude when it comes to the development of the block I'm about to describe. And the other thing is that we are really early on in the development of this new block, and I want to say that what I present to you today is our current understanding as of April 2018, and without a doubt it will continue to progress as we go on forward in the months to come, in the years to come, and we're going to see an accumulation of evidence. But here's where we stand right now. So what is the ESP block? Essentially, it's an ultrasound-guided technique, a paraspinal block involving injection into a musculofascial plane, and this musculofascial plane is located between the erector spinae muscle and above the transverse process. And by injecting into this plane, we achieve a blockade of the ipsilateral thoracolumbar spinal nerves. The development of the ESP block is quite a fascinating story, and it really illustrates, I think, the intersection of serendipity as well as scientific investigation. Mauricio Ferrero, back in 2015, was presented with a 67-year-old man who had a 4-month history of severe neuropathic pain that radiated from his spine all the way into his anterior chest. And it appeared to be located mainly over the T5 dermatome, but also extended slightly inferiorly. And when Mauricio examined him, he located a trigger point some 3 to 4 centimeters lateral to the T5 spinous process. At that point, the diagnosis was unclear. He had had negative MRI imaging, and it was really thought that perhaps this was some sort of weird neuropathic pain, perhaps stemming from postherpetic neuralgia. Mauricio decided that he would combine the principles of a trigger point injection as well as that of a serratus plane block, which is another musculofascial plane block involving injection of local anesthetic between two muscles. Therefore, he placed his ultrasound probe over the area where the patient was reporting the pain seemed to be originating from, which happened to be over the T5 transverse process. He imaged the muscles that lay below the skin, being the trapezius, rhomboid, and then the erector spinae muscle in that order from superficial to deep. And he placed his needle between the rhomboid and the erector spinae muscle, simulating what we would nowadays call a superficial serratus plane block. And he injected 20 mils of 0.5% ropivacaine. What then happened was quite remarkable. The patient reported complete resolution of the pain within 10 minutes. He also reported a loss of pinprick sensation extending from T2 to T9. And this analgesia that he obtained lasted almost 36 hours. When the pain did recur, it did so at a lower intensity of 3 out of 10 pain. As a result, Mauricio repeated the block and then finally inserted a catheter so that he could do top-ups without having to keep inserting a needle into the patient. Now, at this point, the obvious question that arose in our minds was, how is this block working? And initially, based on this plane spread, we thought this must be anterior spread of injectate to the lateral cutaneous branches of the nerves. And so we thought that by injecting above the erector spinae muscle, it was somehow spreading all the way into the mid-axillary line and catching those lateral cutaneous branches. We therefore decided to investigate this a little bit further by injecting some contrast at his next visit and performing a CT scan of the thorax to see where that injectate was going. What surprised us when we did this was that there was no evidence of lateral spread of injectate. As you can see here in this image, all of the injectate is confined to the paravertebral gutter. But what was more remarkable was that we identified the cause of his pain, and it was not a neuropathic pain as such, but rather there was destructive lesions of the 5th and 6th ribs identified arising from bladder cancer. What this then implied to us was that the analgesia that he had obtained could not solely be due to blockade of cutaneous branches. There had to be analgesia that was affecting nerves supplying the bony structures of the ribs and surrounding muscles. At this point, the third player in our little group entered the scene, Dr. Sanjeev Adhikari out of Penn State Hershey, and together we conducted some cadaveric studies to try and elucidate the exact mechanism by which this block was having its effect. Our initial investigations involved injections superficial to the erector spinae muscle, just as Mauricio had initially done, but what we discovered with this was that we mainly obtained staining of the posterior surface of the muscle with very minor tracking through the plane between longissimus thoracis muscle and iliocostalis muscle, which are the two components of erector spinae muscle. However, when we perform injection deep to erector spinae muscle, we found now that the dye was staining the ventral rami and the foraminal areas, and thus achieving spread to the dorsal rami and the ventral rami. In subsequent clinical cases as well as subsequent cadavers, we found that this was the optimal plane for injection, and this is how we currently advocate that the ESP block should be performed. Our article was published in 2016 in Regional Anesthesia and Pain Medicine, and it describes the evolution of this technique, both from the superficial injection to the deep injection, which is now, as I said before, the established technique. And in that report, we report 2 cases of chronic thoracic pain, 2 cases of video-assisted thoracoscopic surgery, as well as the results of our cadaveric investigation. And we performed CT scans in these cadavers as well. And you can see here that spread from an injection point at T5 spreads again in the paravertebral gutter, going all the way up to T1, down as far to T8, and some spillage too laterally into the intercostal spaces. So at this point, the ESP block produces this remarkable clinical effect, this remarkable cutaneous coverage. Is there really a plausible scientific mechanism for this to happen? Or is this just voodoo? What we understand right now about the mechanism of action, and this may continue to evolve, but the first principle that we've come to realize is that local anesthetic solution tracks extensively within tissues. So the image on the left of staining of the interior side of a chest wall is actually something that arises from a very, very similar technique called the MTP block, or midpoint transverse process to pleura technique, which was described by Kostash and colleagues in anesthesia in 2017. And what they did was inject just a little bit deeper to the erector spinae plane, but what they found was that there was spread all the way into the paravertebral spaces and the intercostal spaces, as well as the erector spinae plane. Similarly, when we have injected in our erector spinae plane deep to the erector spinae muscle, you can see on the right side image, which is an MRI image, that there's this extensive lateral spread into the intercostal space, staining of the muscle, and even into the epidural and paravertebral space. The second principle that underlies what we think are the mechanisms of action are that the paraspinal connective tissues are much more porous than we think. There are perforations in the intertransverse connective tissues that allow local anesthetic deposited under the erector spinae muscle to trickle through anteriorly and thus reach the paravertebral space and the epidural space. Such perforations exist to allow the dorsal rami and accompanying vessels to arise and ascend to the surface to supply the back muscles and the cutaneous tissues of the back. And these are called the foramen of Cuvier. This video, kindly supplied by members of the Latin American Regional Anesthesia Society, show clearly that we have local anesthetic tracking through from the erector spinae plane towards the vertebral column. This principle was actually described as far back as 2005 with regard to the retrolaminar block. And Pfeiffer and colleagues, who are German anesthesiologists, described being able to perform a paravertebral laminar technique whereby injection of local anesthetic onto the lamina produced diffusion through into the paravertebral space through these intertransverse gaps. We have investigated this in a recent study about to be published in Regional Anesthesia and Pain Medicine, in which we perform both the retrolaminar block and the erector spinae plane block in fresh cadavers and then put them through an MRI scanner. On the right image, you see the results of a retrolaminar block. The injectate is clustered very, very closely around the lamina, and there is spread into both the epidural space as well as the space around the neuroforamina. And this really mirrors what Pfeiffer and colleagues were describing all the way back in 2005, that it is possible for local anesthetic injected into that surface just above the lamina to actually penetrate through into the paravertebral space. When we look though at the other side where we've done the erector spinae plane block, we see a slightly different pattern. And their erector spinae plane muscle is actually a distinct group from the transverso spinalis muscle, which is a little bit more medial. Injecting under the true erector spinae plane muscle produces spread in that muscle, but also it still manages to track medially towards the epidural space and the neuroforaminal spaces. But more than that, it goes forward into the sympathetic chain as well. The unique thing about the erector spinae plane block, however, compared to the retrolaminar block, is the fact that we get intercostal spread, which you can see illustrated there. And that seems to account for a large part of the effect of the erector spinae plane block. Ushima and colleagues have also published a similar study as an item of correspondence in the Journal of Clinical Anesthesia, in which they describe performing ESP catheters at T6 in 3 patients suffering from chronic lung cancer. And they injected radiocontrast and performed fluoroscopy, and they described that they were able to observe spread to the paravertebral space across at least 5 intervertebral spaces in all 3 patients. When they injected local anesthetic, they obtained a similar spread across 5 dermatomes, producing loss of cold sensation and pinprick sensation in their patients. So I think based on what we know now, we can fairly confidently say that there is a good anatomical basis for the mechanism of action of the ESP block being spread of local anesthetic laterally into the intercostal spaces, but also anteriorly into the paravertebral space and spilling even into the epidural space. Because of that anterior spread, there is the potential for it to reach the sympathetic chain and thus provide not only somatic analgesia, but also visceral analgesia. Again, one of the unique things about this block as opposed to other more anterior chest wall blocks or even abdominal wall blocks is that we anesthetize the dorsal ramus of the spinal nerves, and that provides analgesia or anesthesia of the tissues of the back. So if we're talking about back surgery or spine surgery, this is a distinct advantage. The ventral ramus, which leads on and becomes the intercostal nerve, is also anesthetized. And by blocking it so proximally, we end up blocking not only lateral cutaneous branches, but also anterior cutaneous branches, thus explaining the hemithoracic pattern of analgesia that we saw in our sentinel case. And finally, the third mechanism of action that I think is important to understand that seems to have arisen from what we observe with the ESP block is that we really only require a small amount of local anesthetic to reach target nerves in order to effect an analgesic block. In going back to some old studies that looked at the issue of whether one could achieve differential block, Ford and colleagues conducted experiments in some live cats, and what they found was that when they applied very, very dilute bupivacaine, 0.05% to nerve fibers, they were able to achieve 100% blockade of C fibers, and C fibers are what conducts what's called slow pain. It's 70% of nociceptive fibers. They were able to block 100% of them, yet only result in a less than 50% blockade of A gamma, which are motor neurons, and less than 80% blockade of A delta fibers, which carry cold pressure and also what's known as fast pain, the kind of pain that mediates the withdrawal reflex. When they reduced the concentration even further to 0.025%, that 100% C fiber block was now achieved with even less blockade of both the A gamma as well as the A delta fibers. And I think that this can underlie a lot of what we see clinically with the block when we do the ESP block. Because it's such an indirect block, we are not getting a huge mass or a huge concentration of local actually reaching and acting on target nerves in the paravertebral space or even the intercostal space. And thus, occasionally when we do this block preoperatively, you will note that patients experience or appear to experience pain, and you need to supplement analgesia. And I think it's this sharp pain, this acute pain that's experienced that's not always completely blocked to the same degree that the pain carried by C fibers is blocked. Similarly, this explains a common observation that we don't get motor block, and that sensory loss to pinprick and cold when attempting to map out the dermatomal distribution of the block is not always clearly evident. So I think, given what I've presented so far, we're at the stage where there is a plausible scientific basis for this block to work, although we still probably don't quite understand how 6 minus 3 equals 6. I'd like to move on now to the performance of this block. In preparation for the block, it's useful, I think, first to think about the local anesthetic that you're going to use and inject. In general, because we are treating this as an analgesic block, a long-acting local anesthetic is the best choice. So something like bupivacaine, or if you have it available, ropivacaine or levobupivacaine, because of their superior cardiotoxic profile. The next is to think about the volume that you want to inject. And here the principle is to ensure that you're injecting enough that will give you the spread that you want. Generally in adults right now, most of us would use anywhere from 15 milliliters to 30 milliliters. Whether you use more or less, one factor to consider is whether you're thinking of performing unilateral or bilateral blocks. When it comes to pediatrics, the consensus among my colleagues who do pediatrics is that we use 0.1 to 0.3 milliliters per kilo, similar volumes to what's being used in TAP blocks and other fascial plane blocks. It's also been advised that you can track spread in real time in children just because it's so easy to image their fascial planes. When it comes then to the concentration, you calculate that based on the volume that you've decided to use and the maximum recommended dose per kilo weight of the patient. This usually results in the use of bupivacaine 0.125% to 0.25% or ropivacaine 0.2% to 0.5%. But these are ballpark figures and they can be tailored to your patient. We recommend that epinephrine should be added routinely, mainly to minimize systemic absorption, which may prolong the duration, but more importantly may prevent local anesthetic systemic toxicity, particularly if you're using doses close to the maximum recommended dose limits. As to whether other additives such as dexamethasone or dexmedetomidine will actually act to prolong the block, this remains to be discovered. It is commonly done and extrapolated from the studies on peripheral nerve blocks, and probably at this time there's no evidence that they cause any direct harm, so they can be used if you think it is appropriate. Selecting the probe, we do recommend that a linear array probe only be used if the depth to the transverse processes is sufficiently shallow, so less than 4 to 5 centimeters, because any more than that and the image quality starts to deteriorate and the field of view tends to become quite narrow. If that happens to be the case, we do recommend using a curved array probe because it will give you a wider field of view and much better image quality at depths exceeding 5 centimeters. And in this block, contrast and penetration is much more important than resolution. Choosing a needle for this block depends whether you're thinking about doing a single shot block or a catheter. The good news is you can use any block needle that you're used to using for your peripheral nerve blocks. In general, you want something that is at least 80 millimeters long in most adults. And in children, a 50 millimeter needle is probably all you need. We do find that echogenic needles are helpful in visualizing the shaft as you're approaching in the tip. So if you have them available, again, they are recommended. If you are going to insert a catheter, I would say that you can use any nerve block catheter set available to you, or if you don't actually have nerve block catheter sets, an epidural catheter set will work just as well. There has been a vogue among some of my colleagues to use the newer catheter over needle sets. The one caveat being that you should be aware that some of these may dislodge over time if you don't have enough of the catheter sitting in the ESP plane. So just be mindful of the design of the catheter. Ideally, you want to have at least a couple of centimeters of the catheter sitting in the plane, because there can be expansion and contraction of the overlying erector spinae muscle, which can draw your catheter out of that plane. Finally, I think it's very important to always ensure that you have some non-active fluid loaded onto your needle to use in the initial process of hydrolocation. Getting into the right space is vital to the success of this block, and what you don't want to do is end up wasting your local anesthetic by performing multiple hydrolocation attempts. And then worse is that you refill your syringe with local anesthetic and then run into the risk of overdosing the patient with local anesthetic. You have to access the back of the patient, and thus you need to put the patient in one of these three positions: either sitting, either lateral, which lateral works well for postoperative rescue blocks, or prone positioning. That's probably the most ergonomic, but involves the most trouble in terms of getting patients to flip over and flip back again, especially if surgery is going to be performed in a position other than prone. When you start scanning, the first thing is to think about which vertebral level you want to target to do the block. The general principle is that this target transverse process should be congruent with the center of the surgical incision or the painful area that you are trying to treat. A rule of thumb, if you want to follow one, is that if it's a thoracic application, anywhere between the T3 to T5 levels is appropriate. If it's the upper abdomen, anywhere from T8 to T9. And if the lower abdomen, T10 to T12 will be sufficient. You can identify the transverse process and the target in one of two ways. You can start with a transverse view, in which case you place the probe over the midline to identify the spinous process, and you move it gradually laterally to identify the transverse process tip, which rises up from the lamina, and you just want to make sure that you don't mistake it for the rib, which will lie out a little bit more laterally. You can then mark the position of the tip of the transverse process on the skin, or you can center it in your screen and gradually rotate into a parasagittal orientation. Alternatively, if you just want to start straight away in a parasagittal longitudinal orientation, I suggest that you place the probe laterally where you know you're clearly over the ribs, which you will then recognize by their characteristic rounded shadow, as well as the hyperechoic reflection of the pleura deep to those ribs. When you then slide very slowly medially towards the tips of the transverse process, what you will see is that these shadows of the ribs transition into a quite different bony acoustic shadow of the tip of the transverse process. They tend to be a little bit more squared off. They're often more superficial. And what's quite important is that you see that the pleura becomes less visible, because what it does is it starts to curve anteriorly towards the spine. Those are the indicators that you're now imaging the tip of the transverse process. And then you want to identify the muscle overlying those bony shadows, which will be your erector spinae muscle. Put your chosen transverse process into not the center of the screen, but off to one side. You actually want to be aiming using a fairly shallow needle trajectory. So you don't want to have your probe necessarily in the middle of the screen, because that usually mandates a 45-degree angle, and I do recommend that your angle is less than that. You gently aim to strike the transverse process without causing too much pain, and I advocate too that you should aim to strike what I say is what I call the far side of the transverse process, the side further away from your insertion point rather than the side that's closer to your needle insertion point. And the reason is that you may occasionally need to go just a little bit deeper to find that plane that you want to open up. When you do strike bone, however, you do want to withdraw very, very slightly, because if you don't, you often find that it's difficult to inject because your muscles, your needle tip is embedded in periosteum. Inject 0.5 ml of fluid at this time to see where you are. If you are in the correct plane, what you see is this very characteristic linear spread of local anesthetic that lifts the erector spinae muscle up off the transverse processes. And one feature of this correct spread is that it occurs in both directions. It goes in the direction that you are injecting, but you will also see expansion in the reverse direction. Some pearls and pitfalls to be aware of. In the awake patient, they can occasionally find the needle insertion painful through the muscle. That can usually be solved by anesthetizing the muscle with a slightly longer infiltration needle. And that longer needle also serves a secondary purpose in that it helps you to ensure that you are going to be in line with your beam when you finally do insert the block needle. Because in-plane alignment and needle visualization, as we all know, can be difficult at the best of times. The hindrance here is that you haven't got the latitude to be able to move your probe to find your needle, because if you do that, you will lose the picture of your target. So you often either have to move your needle or you have to make a new skin puncture to ensure that you end up exactly in plane. So I'm usually very, very meticulous about making sure I'm in a good position to maintain alignment, and very, very careful to ensure that I do put the needle into as close to the midpoint of the probe as possible to begin with. And finally, as I've alluded to, sometimes getting into that correct tissue plane can occasionally be difficult. You're either stuck in periosteum, a bit too deep, you pull back, and then you're intramuscular. And this is where aiming again for that far side of the transverse process, as I mentioned, is helpful, because what you may have to do is to skim off the edge of the transverse process to go just that touch deeper to get right under the fascia of the erector spinae muscle to open it up. At this point, I'll show you some videos to illustrate both what is a suboptimal injection as well as optimal injection. So this first one is an example of intramuscular injection. And you can see here that the needle is landing on the near side of the transverse process at a fairly steep angle. And although we're touching the bone when we inject, you can see here that the erector spinae muscle is expanding. So we haven't actually entered the plane deep to the fascia of erector spinae muscle. Readjusting, we flatten a little bit. We go a little bit along the transverse process to try and just slip off it a bit. And now when we inject, you can see that the muscle, instead of expanding, is actually lifting up off the transverse process. And this is an example of the correct spread that we want to see. Another video I'll show you in a patient who's got slightly more superficial transverse processes. The needle is coming in, this time at the appropriately shallow angle. You'll notice the compression of muscles that I was talking about, which may tend to dislodge catheters. Here the needle comes in, and once again we're striking the midpoint of the transverse process, and we're getting this intramuscular spread. So we need to go a little bit deeper. Another test injection at this point produces that lifting that we see. And now you can see the tip of this needle, which happens to be a Torii needle, sitting in a plane of local anesthetic that, as we inject, opens up, spreads in both directions, and lifts the muscle off the transverse process. Once we've opened up that pocket with 10 to 20 mils of fluid, it's usually quite easy to thread a catheter into that space, as you can see here, and it sits quite nicely in that space. And by injecting fluid through the catheter and seeing again that characteristic linear expansion, we know that the catheter tip is in a correct position. I do believe that catheter insertion is desirable if it fits within the anesthetic plan for a couple of reasons. The main reason being that you can top the catheter up in the postoperative period, number one, to augment analgesia, but also to prolong analgesia. And when we talk about using the catheter for post-op infusions, there are a variety of regimens that can be used. We don't have enough evidence at this point to comment as to which is superior. But if you are using a continuous infusion, what we do know is that you need rates that are higher than you might expect for a peripheral nerve. And again, it's because our catheters are sitting further away from target nerves, and we just need that extra volume to carry enough local anesthetic to those target areas. So people have reported using anywhere from 7 all the way up to 15 milliliters per hour, again being cognizant of the risk of local anesthetic systemic toxicity. If you happen to have a patient-controlled bolus function on those continuous infusion pumps, they perform a useful function in allowing the patient to augment their analgesia as necessary, and their setting boluses that range from 5 to 10 mils with the appropriate lockout interval is a useful option. We've also had people use manual intermittent boluses, and now with the advent of program intermittent boluses on pumps becoming more widely available, these present an attractive option. And setting boluses between 10 to 20 milliliters, probably every 2 to 3 hours, is a good option. But once again, being mindful of the total amount of local anesthetic that you're delivering. So I'm going to sum up by saying, why should we be performing an ESP block? Do we really need this new block over established techniques like paravertebrals and thoracic epidurals? Well, I think the main attraction of the ESP block is that it's a block that's technically easier and thus puts it within the reach of a lot more of our anesthetic colleagues. We've even seen reports now coming out of the emergency department where emergency physicians are using this in chest trauma. It's theoretically safer, and again, it's something that a lot more practitioners are going to feel comfortable doing versus a paravertebral or an epidural. You're further away from the lung. The risk of pleural puncture is very remote because you've got the backstop of the transverse process. You're nowhere near the neuraxis, so the risk of epidural hematoma or even an epidural abscess from an indwelling catheter is going to be pretty minimal. And I have to say, when talking to patients about the block, every time you tell them you're going to do an injection in their back, they always are saying, I don't want a needle in my spine. And I can put my hand on my heart and say, no, I'm not injecting your spine, I'm injecting into the muscles of your back. And then that's okay. And the early evidence, which I must say though is mostly from case series and case reports, but nevertheless, it appears to be as effective as thoracic epidural analgesia or even thoracic paravertebral blockade. There are unique advantages, though, that it does have over these blocks, apart from the safety aspect. Certainly, we see extensive craniocaudal spread from a single injection point, usually spanning at least 4 or 5 dermatomes. And we attribute this to the fact that we're injecting within a muscle plane versus the fat-filled space of an epidural or paravertebral space. And that graph is from a study in paravertebrals, and the blue columns represent the MRI spread that was observed, which, as you can see, is fairly limited. The plane, once you open it up, is also very amenable to catheter insertions. They thread well and they tend to stay in place. And if liposomal bupivacaine is something that you have available, these have started to be reported for use in the Erector Spinae plane block, although it may not be FDA approved at this stage. But if that comes along, it falls within perhaps the same category as the use in TAP blocks, and they can be explored in the Erector Spinae plane blocks. The other exciting thing is that the Erector Spinae muscle extends really from the cervical region all the way down to the lumbar region, and thus is accessible and potentially can be used for applications other than just thoracic or abdominal analgesia. And we are seeing early reports coming in of applications in these areas. Nevertheless, nothing is perfect, and it's important to be aware of the current limitations and the risks that might be associated with this technique. I think the number one limitation is that the block that you will observe and the patient will experience tends to be of variable intensity. They can have excellent analgesia and they can have moderately good analgesia. The duration also happens to be variable, and we think that is perhaps due to vascular absorption that occurs, and thus again we recommend that you insert a catheter whenever possible so that you can compensate both for the variation in intensity and variation in duration by rebolusing that. Similarly, please bear in mind that local anesthetic systemic toxicity is a real risk. All of these fascial plane blocks are into muscular planes that are well vascularized, and thus local anesthetic absorption does tend to occur, especially because we use such large volumes. So as I've said before, we recommend adding epinephrine to your blocks, even if you are using ropivacaine. You should always respect the maximum limits for local anesthetic doses. And remember that when you are doing that process of hydrolocation, use non-active fluid so that you're not wasting the local anesthetic that you intend to deposit into the space. It goes without saying that patients need to be closely monitored both during the block as well as for a period afterwards. But on the flip side, there is a theoretically minimal risk of all these bad things happening that are associated with the alternatives of paravertebral block and epidural block. Now, we talked about the fact that we have seen spread that occurs into the epidural space. So this raises the question of, are we going to see hypotension with the ESP block? It certainly is possible, but if you think about the fact that we are getting less local anesthetic spreading actually into the epidural space, the degree of sympathectomy is going to be much, much milder and minor compared to something like an epidural. So significant hypotension at this stage is not something that we're seeing consistently reported. I haven't seen it myself, and it's something that's likely to be rare. We still though have many unanswered questions. So we talked about this variability. So large series and randomized controlled trials are required to establish just how reliable these blocks are and whether there are any more tweaks that we can do to the technique or to the dosing of drugs that will make them more reliable. We need to see the comparative trials to establish just how well they compare to epidural or paravertebral, both from an efficacy point of view, but also from a safety point of view, because as I said, a well-sited epidural is not much use to you if it's going to make you concerned about hematoma, abscess, or about hypotension, and you're not going to use the epidural as it is intended. It may turn out too that the utility of these blocks is population dependent. There may be certain populations where epidurals or paravertebrals still prove to be the superior choice. And how in fact these blocks all compare to each other. For now it is an analgesic block. It has been reported for use in anesthesia, but I would say that these tend to be more superficial surgeries. If we are using single shot blocks, are there ways to maximize durations, the role of additives? And when we are using catheters, is there an optimal dosing regimen? Intermittent bolus or infusions? What rate to use? What volume to use? These are all questions that need answering. So when to use the ESP block, I would say it's as an alternative to the thoracic epidural or thoracic paravertebral in your practice. If you're thinking about using them, but the patient either refuses, in your estimation, it's not a safe block to perform, when it's not feasible for either patient factors, practitioner factors, or environment factors such as the lack of monitoring necessary for an epidural, this is when the ESP block becomes an option to use. It's simple, it's safe, the evidence is that it's reasonably effective, and so really there is often nothing to lose by offering it to a patient. So our present conclusions are that this is a developing block. It presents an alternative to epidurals and paravertebrals when those are not feasible. I think we have a sound anatomical basis at this stage to explain the block. It certainly is a simpler block to perform compared to those other alternatives. I think it is safer from a theoretical point of view and almost as effective. Remember that you should go into it expecting it to be opioid sparing, but certainly not eliminating. Be prepared to use other analgesics as necessary and really use it as part of your overall multimodal analgesic regimen, and you won't be disappointed. These are some links to online resources that exist as of April 2018, and no doubt more will come, but you may find further details at these websites. Thank you.